Strokes. Okay, strokes very high yield and very high yield for a reason. So if we want to put strokes under the umbrella of cardiovascular disease, it can be associated with the number one cause of mortality. If you want to separate it, then it's going to just on its own going to be the number four cause of mortality. It's a big one. It's up there, and even if you survive, 50% of people are going to be chronically disabled. I mean, speaking from an experience, this is a real motherfucker. This disease. 3 out of 4 of my grandparents all suffered strokes. None of them died from it, and just a huge impact on your quality of life. My girlfriend's father, it's just awful. So you're going to see this all the time. You know, we go over some really obscure, like, neurocutaneous diseases. You might never see a patient or see a couple patients your whole life. You will see a ton of people with strokes. So 2 different types of strokes. There's ischemic strokes where there is just not enough blood supply getting to an area. This is by far the most common one. This is 85% of strokes. And then we have hemorrhagic strokes where there is a bleed in the brain. It's not contained. So we can go ahead and break this out to a little bit more of a complicated like web. I think it's really important to have all of these organized in your mind. So ischemic, we have embolic, so like an embolus, a clot that is traveling from a foreign region. A thrombus, just, you have atherosclerosis and you're just building up like a clot in the local region. A lacunar stroke, so this is going to be ischemia of a really small vessel. It leaves a little hole, little lacunae in the brain. And then a hypoxic, so let's say you get shot with a gun, you're bleeding a lot, you get in a hypovolemic shock, you don't have enough, you're having a hard time adequately perfusing the brain, so you can get hypoxia there. That's going to affect watershed regions, which we'll talk about. And this is also just going to be very much in the basal ganglia. I just want to say that now. We'll say that again later. Hemorrhagic. All right, so we got epidural and subdermal. Both of these are hematomas. So this is going to be from trauma. And then subarachnoid and intracerebral are going to, not always due to aneurysm rupture, but often associated with rupture of an aneurysm. Ischemic strokes can become hemorrhagic strokes. So there's like a reperfusion injury. So if there's ischemia to a tissue, I'm not exactly sure why. I'm sure a lot's going on, but I always just thought like if there's ischemia to an area, the vessels get weak and damaged because they're ischemic. And then suddenly if we have tons of blood flowing in, it might be more pressure than that like kind of weak tissue can deal with. And it might cause like a rupture. And so that might be a hemorrhagic stroke. I'm sure there's a lot more going on there and maybe that's totally wrong, but that was what I thought. Vasospasm. So we can go the other way. Hemorrhagic stroke, if we're losing blood, there's a lot of chemicals in the blood that's getting into the surrounding interstitial fluid that can affect vessels and cause them to constrict. And if they're constricting, then that means downstream of that, we're not getting enough blood flow. So this can cause ischemia. All right, so again, 85% ischemic stroke, far more common. We have thrombotic, and so this is just going to be the usual suspects. What is promoting atherosclerosis, smoking, obesity, etc. So it's usually arterial thrombosis. You could also have venous thrombosis. Certain people have genetic mutations or taking oral contraceptive pills or whatever that are, or they have cancer, something that's putting you in a hypercoagulable state. Then we have embolic strokes. So usually this is coming from the carotid artery. Because most deep vein thromboses are going to get caught by the lungs coming from the legs. But it could, if you're coming from the legs and you have a PFO, patent foramen ovale, it could go right through from the right atrium to the left atrium, left ventricle, then pump right up to the brain. Or if you have atrial fibrillation, you can have blood stasis, you can get a clot, that can go up to the brain. Or if you have infective endocarditis, unlike your mitral or aortic valve, this is thrombogenic, and this could cause a clot, and that could go to the brain. Lacunar, we said again, is going to be the small but deep penetrating arteries off of typically the lenticulostriate arteries off of the MCA, which is feeding the basal ganglia. A lot of different reasons: hyaline arteriosclerosis, microatheromas, fibrinoid deposition, and they leave these little lacunae, these little holes, these lakes. MCA is just the most common. Just note that's so important. It's the most common one. It's so common. You guys have probably heard the acronym FAST. I used to be an EMT and we had FAST, right? Someone's having a stroke. How do we know? You see the face drooping, you see the arm weakness, they're having difficulty with speech, and then time is just critical. Well, this fits perfectly with an MCA stroke, right? This acronym was literally made because most strokes are MCA strokes. if you have Wallenberg syndrome, lateral medullary stroke, that's not going to cause these symptoms. If I have an ACA stroke, it's not going to cause these symptoms. The reason is that the MCA is going to be over here, and this is the arms, as we can see, and this is the mouth and throat. So we're going to have trouble with speech, and the face is going to droop as well. So that's why they just connect that with this mnemonic. That's just really highlighting MCA is the most common. All right, lacunar strokes back here. So lenticular striae off the MCA, go figure, right? So the MCA is the most common stroke, and so it kind of makes sense that one of the smaller vessels branching off this is also going to be quite common. It can affect the corona radiata, which is just these axons projecting down from the cortex. The internal capsule, which might be under the umbrella of the corona radiata, I'm not sure, but this is going through, I think it's right, this is the lentiform nucleus right here, and maybe this is the thalamus, but it's just in the basal ganglia, we have this little stretch where axons can move through. It can also be the pons, but I would typically associate it with the basal ganglia. Probably the internal capsule is the best one. Cortical signs are absent. So what is a cortical sign? Something like, okay, I have a stroke in my, let's say I have right arm weakness, right? I have right arm weakness. Okay, that could be the left MCA, right? But if it's the left MCA, it might also hit Broca's area. So maybe you're trying to wonder, like, why is Will having a hard time speaking? Is because my MCA, it could be Broca's. Let's just say it's going to be the Broca's area is damaged. So I'm having trouble forming words. That won't happen if I had damage to the left internal capsule, right? The left internal capsule might also go to the right arm, but you're going to not have any cortical signs. That's what we mean. So this is not going to be cortical signs. So aphasia or something like visuospatial neglect, right? Where you can't recognize faces or make sense of things, etc. And watershed region. So let's imagine you have a town and it's, there's electricity being supplied to some big city over here. This is city number 1, and a bunch of electricity being supplied to city number 2. And this town is like really far out in the middle of nowhere, that it's like barely being supplied by both cities. So if one of the cities goes down, or if like there's just like, let's say there's like a war in Ukraine and we're having a hard time getting like, energy for a good price, this town might be a little bit screwed because it's kind of like, it's far away from both of these places. And we're seeing that here. We're looking at this watershed region. This tissue is kind of being perfused by this city and kind of being perfused by this city. But if you have less perfusion because you've been shot and you're bleeding out, you're going to have tissue being deprived of oxygen there. Again, this is not to be confused with something like the macula part of the occipital processing. Where it's not that it's in between two big cities, it's like being very much supplied by two cities. So that's going to be collateral circulation. That's different. All right, we've already kind of answered this. What happens if there's global hypoperfusion? These watershed regions, something like in between the ACA and the MCA. Oh, let's look what's in between the ACA and the MCA, right? The green is for the MCA and yellow here is for ACA. Something like the hip, the trunk, the shoulder are all going to be affected. You get this something called the man in a barrel syndrome, where you have a hard time moving your shoulders and hips, and you're going to have this very notable way of moving and walking. You could also have something in the PCA and the MCA. I don't actually remember what my point was, but really I just want to emphasize this macular sparing because it is not a watershed region. It's super supplied by two different regions. Not a watershed, but I would just know the cerebellum and the hippocampus are very, very, very hungry for nutrients, and so very vulnerable to ischemia. Whenever you have tissue damage, it's almost always coagulative necrosis, except from the brain. For whatever reason, lysosomes spill out and causes everything to become what's called liquefactive necrosis, and it just sort of liquefies right there. All right, so let's say I do have liquefactive necrosis. I do have some damage to the brain. There's ischemia or hemorrhagic stroke or whatnot. Just what's going to happen? Well, we can same thing we did in the heart, same thing we're doing in most places. We're just, imagine that Times Square gets attacked. Times Square gets attacked by terrorists. You're going to have damage. You're going to have SWAT teams come on. And then, like the SWAT teams are going to come on the day, a few days. And a couple of weeks, months later, SWAT team leaves, but the police officers are going to patrol the site in case there's another attack and just to make sure that, the construction crew can get around and whatnot. Construction crew is then going to repair everything. And at the end of the day, it's going to be repaired, but maybe we have some sort of like memorial, some way of remembering it. So what the heck am I going on about? Initially, you're going to have eosinophilic cytoplasm with pycnotic nuclei. In other words, you're going to have these red not red nuclei, but red neurons. And this is because Nissl bodies, rough endoplasmic reticulum fragments, have RNA. RNA is an acid. Acids stain with blue basophilic stains. So if we don't have those, they're chromatolysis, they're being degenerated. I'm now going to have just red left over. Then the neutrophils are going to show up and going to contribute to the necrosis. So there's our neutrophils. The macrophages or the microglia in the brain, they're going to come over and just patrol. So again, we're going to have like first 24 hours, couple of days to a couple of weeks, couple of weeks to a couple of months. The astrocytes and reactive gliosis is going to come in to repair everything. And at the end of the day, this is the microglia. This is the reactive gliosis. I might have screwed that up. And at the end of the day, you're going to have some sort of all of this, these fibroblasts laying down like scar tissue, basically. And so that's the memorial or the fact that we didn't ever fully heal our city, is that we have this. And it's debatable whether or not reactive gliosis is good. I think we should kind of lean towards it being maybe a bad thing here. A TIA is a transient ischemic attack. So it's kind of like angina. Angina is like just heart pain, but it's not like a full heart attack, a STEMI. And this is kind of similar. It's like a mini stroke without significant infarction. So remember, infarction is blood is cut off and you get necrosis. Ischemia is just you get deprived for a little bit. So it's going to be ischemia, a little bit of infarction, but not much. It's just going to be a brief focal neurological episode that lasts about like 15 minutes or less. The thing about this, though, that it's an omen. It's maybe we could call it a wake-up call, but maybe it's a little bit too late. If someone has a TIA, maybe they're fine, but I think 50% of people have a much bigger real stroke within the next 6 months. So, maybe they can radically change their diet or start medications, or maybe they can't do much and it just sucks. They just got to sit and wait and know a big stroke's going to come. I don't really know, but I think that's how we should think about it. All right, so someone comes in with a stroke, then they got this blood clot, we're pretty sure they got a stroke that's going on, right? They FAST, they're having trouble moving their arm and speaking and whatnot. Shouldn't we give them TPA, tissue plasminogen activator, to go ahead and bust up the clot? No, because remember, 85% is a big number, but we still have 15% of strokes which are hemorrhagic. And this is kind of the opposite problem. Ischemic, we have a clot. Hemorrhagic is we have too much bleeding. So if someone comes in and they're having a stroke and we just give them TPA and it turns out we're wrong and they actually have a hemorrhagic stroke, we're going to make it way worse because we're preventing clotting from forming, and we need clotting to form. So the ischemic would get better in that case, and this would get much worse. So what we do is a patient comes in, we give them a quick CT, we get some lab results, and we try to, as quickly as we can, give them TPA. I think the thing is like TPA only works if you get a patient within the first 3 or 4 hours, which again, T for time. Time is very important for strokes. All right, so we did all of the ischemias. Let's now move over and look at the hemorrhagic strokes, the brain bleeds. All right, epidural is outside of the dural layer. Subdural, it's right below the dural layer. Subarachnoid, it is right below the arachnoid layer in the subarachnoid space where the CSF is. And then intracerebral is just anywhere in the brain parenchyma. It could be in a bunch of different places. All right, so let's start with the hematomas. Epidural hematoma is the rupture of the middle meningeal artery off of the maxillary artery off of the carotid. It's in the temporal bone, so it's going to be kind of like here-ish. And so when this is accumulating all of this blood, again, epidural, outside the dural layers, it cannot cross the suture line. So look at these suture lines. So if I get blood accumulating here and it's going to try to go over here, it can't cross there. You shall not pass. It cannot pass that. So it's just going to accumulate here. So as a consequence, let's say that this is a suture line and this is a suture line. You cannot cross. It can't cross there. So it's just going to start bulging out this way. And you get this little kind of lens crescent shape that forms. It's very characteristic of this crescent shaped lens, convex lens specifically. Just how do you get this? Somebody gets hit in the head, and that ruptures the meningeal artery, and you get a brain bleed. It's going to fill very quickly. because it's an artery. Arteries are gonna leak blood a lot more than faster than a venous structure would. And also the suture containments means that it's not allowed to relieve pressure, but kind of spreading out. It's just going to kind of build and build and build in like a smaller space that's a little bit more compressed and contained. So huge amounts of pressure and very high yield as you have these lucid intervals. So very sad story is I was a kid, and I just remember walking out one morning and seeing my neighbor, some 50-year-old woman, just absolutely sobbing, and it turns out we went over, and her son, who I kind of knew, was this, and I was like 10 and he was like 20, and he was at a party and somebody hit him with a bat, and the guy ran off, and then he went back to the party, and he kept hanging out, and then, like, I don't know, 30 minutes, an hour later, he started getting all woozy and falling over, and they took him to the hospital and did everything they could, but he died. It's just awful. But I will never forget the lucid interval, just because it was described so horribly to me. That they could have done something maybe if they got him somewhere sooner, and that they waited because they thought he was fine because of this lucid interval. Subdural hematoma. So you have these bridging veins. So they can come from the parenchyma, and I guess they can come from the subarachnoid space, but they bridge the sinus with the sort of the inner parts of the brain, the parenchyma and whatnot. So they're bridging across this dural gap. And they can cross suture lines as a result. So if you get a brain bleed, let's say a suture line is right here, that's okay, we can just go right on past it. Suture line's here, that's okay, we're going to go right on past it. And so I guess when I said crescent earlier, I shouldn't have said crescent. The other one is convex lens. This maybe is a little bit more crescent. The point is that a epidural one goes like this, while this one spreads out a lot more thin. This one, I guess, is a little bit more crescent shaped. So just very much know the shapes. You can cross the suture lines, and it is venous blood. And so it can always vary, and there are exceptions for everything, but pound for pound, all else being equal, subdermal is less acute, less pressing than they're all pressing, but less pressing than an epidural. Again, the venous, the fact that it can spread out, is not going to put as much pressure. That can be bad though, right? Because if someone gets an epidural, they kind of know what's going on right away. They come to the hospital. But in this case, people might fall, rupture one of the bridging veins, blood starts accumulating, and it might be a week, 2 weeks, 3 weeks before they start to notice symptoms and come in. And so that's obviously kind of scary. Who's this going to affect? So yeah, it can be from those mild bumps and trauma, and then it accumulates. And that's going to be because people who are elderly, you can rupture their bridging veins a little bit more easily. Alcoholics also, and the veins just become frail. And then a shaken baby. If you shake a baby, their bridging veins, I guess, are also kind of fragile, and they can tear easily as well. Cool. So about we talked about like the fact that this can be over the course of a couple of weeks. So you might have this radio opaque structure here initially. So this is how you could kind of time a subdural hematoma. If it's radio opaque initially, it's kind of like whitish. That means it just happened. But if it's this dark region here, it's a little bit more translucent. Then it's going to be, we can time it, say it must have been a couple of weeks. So again, epidural is skull fracture, meningally artery, does not cross the suture lines, do not cross go, very high amounts of pressure. Subdural is the bridging vein that goes to the sinus, and it can cross, and it's a vein, and so it's definitely a lot of pressure, but not as much pressure. It can build for weeks. Alcoholics, babies, elderly people, this is, people getting hit in the head with something like this. So, they're both usually some sort of trauma, but epidural is a little bit more clear, like extreme trauma. All right, so we have these two dural layers. One of them hugs the cranium. One of them always is going to follow the brain. And we have these natural foldings of the brain for the cerebral hemisphere, and the cerebrum from the cerebellum. And so where this goes down, we are going to have these cerebelli, these tentorium, and we're also going to have this subarachnoid, right here, subarachnoid space here with the CSF and everything. And the point of saying all of that is that we should notice that the subarachnoid bleeds can kind of go in a little bit, unlike the epidural and the subdural ones. So It's typically going to be, I mean, it could be due to trauma, right? It could be due to trauma, and you can see here we have a little bit of blood accumulating right there. But probably more often than not than in your NBME, it's going to be due to a saccular or berry aneurysm that occurs at the circle of Willis at the branch points. So often at the ACOM, at the PCOM, or at the MCA. And so a little bit more in saccular aneurysms, they can lead to a subarachnoid hemorrhage again, so can trauma, but this is probably going to be the main one. People will complain about this is the worst headache I've ever had. This is, I don't know who the heck says I have a thunderclap headache, but that is something they might say. It's associated with African Americans, people with autosomal dominant polycystic kidney disease, people with Marfan syndrome or other connective tissue defects like Ehlers-Danlos. Because this weakens the vessels and allows for these aneurysms to form in the first place. And again, they happen at the circle of Willis, at the branch points. MCA, we know what that does. ACOM, optic chiasm, bitemporal hemianopsia. PCOM is going to be cranial nerve. So look for the down and out pupil and a pupil or down and out eye and a blown pupil because the parasympathetic Edinger-Westphal nucleus tract runs right on the periphery of cranial nerve 3. Also, if you're bleeding the subarachnoid space, that's where the CSF is. Remember, the CFF goes through the ventricular system, gets absorbed via the arachnoid granulations and the sinuses, which drain into the venous system. And so, I mean, potentially you could find it in the blood, but definitely in the CSF. If we do a lumbar puncture, we are going to maybe not definitely, but there's a high chance that we see some red blood cells. Or you might see what's called xanthochromia. And this is, I think, just bilirubin, which is kind of yellow. This is just oxidized hemoglobin. So, again, this in the CSF and a lumbar puncture, you should expect to see this because this is a subarachnoid hemorrhage, which is in the CSF. So you should have some blood in the CSF. And this is just showing where we might get these saccular aneurysms. So, okay, you get a subarachnoid hemorrhage and berry aneurysm ruptures, and you've been in the hospital for a couple of days, and they fix you, you're good, right? Not necessarily, right? So there's complications. We've got to monitor people who have subarachnoid hemorrhages. So a couple of reasons. There might be rebleeding. Actually, the rebleeding is kind of for this, actually. Sorry. So they might be rebleeding. And so we have a beta blocker, labetalol, and nicardipine, a calcium channel blocker. This is going to keep the pressures down so that we're less likely to rebleed. A separate thing, and I kind of organized this weird, is that when you have an aneurysm rupture, you're going to spill all of this blood and stuff over here. And all of these weird chemicals, I don't know, for whatever reason, they cause these smooth muscles to start contracting. And so you get these vasospasms. And that means that downstream of this, you're going to have ischemia. So we mentioned that hemorrhagic strokes can lead to ischemic strokes, and this is sort of why. So you might give nimodipine to prevent the vasospasms. All right, so we've talked about epidural, subdural, subarachnoid. These are all extraaxial types of hemorrhage, like outside of the brain, parenchyma. But then we have this intraaxial one, which is the intracerebral hemorrhage. And we're going to talk about this in 1 second, but I just kind of wanted to set this up as a nice parallel for what we're going to do in the next slide, which is that also extraaxial, again, same thing, subdural, subarachnoid. Here we're talking about traumatic injuries. Here we're talking about brain bleeds, and we might think, well, aren't they the same? Not necessarily, right? So for intraaxial bleed, it's an intracerebral hemorrhage, but for intraaxial traumatic injury, we have diffuse axonal injury, which is really just where the axons are going to shear. They're going to shear. So speaking about traumatic brain injuries real quick aside, like a mild one can result in a concussion, which is actually really difficult to pick up on a CT or a blood test. And I would know the term coup contre coup. So if someone smacks me right here, the whole brain, there might be a massive vac where it could just kind of slides forward and it bangs on the front part of my skull, my frontal bone. So you actually, even though I was hit in the back of the head here, I might also have my brain smack the front of my head and get an injury there. That is a coup contre coup injury. And so if you have lots of concussions of your life, lots of little tiny traumatic brain injuries, they actually kind of like build up collectively. And you can get chronic traumatic encephalopathy. You have enlarged ventricles, the protein tau, because we keep having these these axonal injuries, shear, and we know that the tau protein is going to stabilize microtubules. Remember, it's hyperphosphorylated in something like Alzheimer's, but it's now going to leak out, and we have it accumulating in the just in surrounding tissue. People get headaches, behavioral changes, memory loss, Parkinsonism, and dementia. And this is what a brain looks like after just, boxers and football players and whatnot, just repetitive concussions again and again and again and again. Okay, so going back, so I was just doing the extraaxial, intraaxial to compare the hemorrhage to the brain injury. Back to the main plot, we're talking about strokes. So hemorrhages. What is parenchyma? Parenchyma just means what is the tissue? So, what is the parenchyma of the kidney? It's just the nephrons. Does the nephron have blood vessels? Yes, but that's not unique to the kidney, right? I'm sure there's white blood cells as well, but that is not unique to the kidney. Unique to the kidney is the tubular cells. So unique to the brain is going to be the neurons. So the inside parts. So that's just most of the brain. It's going to be intracerebral. So whenever we're talking about intracerebral hemorrhage, it is, again, remember that the intracerebral ischemic injury is going to be a lacunar stroke. Intracerebral hemorrhage is typically going to be due to we'll talk about it. How we know that it's super crazy associated with hypertension. Both of them are actually, the lacunar and this. Now, as far as the hemorrhage, a Charcot-Bouchard microaneurysm, also associated with hypertension, is going to be found in the lenticular striate arteries, which kind of supply the basal ganglia. And it could result in a lacunar infarct, but that's kind of a different thing, actually. So that is probably going to be our main one for a intracerebral hemorrhage. But it could also be just due to amyloid deposition. And this is actually going to be in particular for lobar hemorrhage. And then we mentioned that reperfusion injury, the tissue might be weak, and if we reperfuse it, it just might be too much blood pressure. In addition to probably a lot of other things going on, just causes a hemorrhagic stroke potentially. And gosh, we're just repeating ourselves, lenticular striate, basal ganglia. Sometimes, or specifically, it could be the putamen. Okay, so brain bleeds, whether it's epidural, subdural, subarachnoid or intracerebral, is going to exert pressure, a mass effect. It is going to shift other structures in the brain and compress them in ways that they don't really want to be compressed. So a couple brain herniations to know. Remember, the cingulate gyrus is going to be sort of like. I guess right now I'm pointing at the corpus callosum, but the cingulate gyrus is going to be just bordering on the cortex and the subcortical structures. So that's going to be kind of in this area. The subfalcine, so we do have the falx cerebri, which kind of goes into the page, out of the page right here. So if you know your anatomy, it makes sense that the subfalcine is going right under that, right next to the corpus callosum. And what artery is right there? The ACA is going to be supplying that particular area. And so that could lead to contralateral leg weakness. Lateral descending transtentorial herniation, better known as an uncal herniation, this is the medial temporal lobe if it's pressed inwards. And it's going to compress cranial nerve 3. It could also compress the brainstem, and if it gets the reticular activating system, that's going to be coma, or it could cause death. We also have a central descending downward herniation. Again, this could hit the reticular formation, cause a coma. It could also, you kind of need your brainstem for breathing and a lot of other things, so that could cause death. If most of these are causing death. If you rupture the basilar artery, this is called a direct hemorrhage, and you're going to be extra dead there. Cerebellar tonsillar herniation. The tonsils are going to be kind of the small inferior posterior aspect of the cerebellum. We see them in Chiari type 1 and Chiari type 2. Chiari type 2 is also the vermis, but depending on how much is being herniated, again, coma, again, death. All right, bunch of arteries. Let's go through them all. ACA, contralateral legs. MCA, think of FAST, F-A-S-T, facial droop, arms, speech, because of, maybe like Broca's or Wernicke's area or something. And this is going to be contralateral face, arms, cortical symptoms, so aphasia. Lenticular striate, contralateral paralysis with no cortical symptoms. PCA is going to be vision with macular sparring, however many times I have to say that. Basilar and pontine is going to be the medial pons. So Corticospinal goes out. Bulbar goes out. Bulbar just means to the face. So you're going to get quadriplegia. And if the reticular activating system is spared, then you'll be conscious. And this is called locked-in syndrome, where you can't, you're aware of everything that's going on, but you just can't move really like any of your muscles, and it's horrible. AICA is lateral pontine syndrome. So remember so this is going to be the lateral pons. So what's in the pons? Rule of fours. We have cranial nerves 5, 6, 7, and 8. Specifically, the ones that are not divisible by 4 are going to be on the lateral. So especially cranial nerve 7, you're going to get this facial palsy with forehead sparing though, right? Because forehead sparing, we have dual innervation for the temporalis on both sides. Cranial nerve 8, so you're going to have vestibular dysfunction. Maybe you're going to have hearing issues. Vertigo, ataxia, because you need the vestibular system for that. Vestibular system can also play a role in nystagmus. On the side, remember, so we have the 4 midline, like motor, nucleus in the center, and then on the lateral side, we're going to have things like sympathetic and sensory and whatnot. So here on the lateral, so sympathetic, so we get a Horner's. Cerebellum has the spinocerebellar tract, the vermis, which gets inputs from the dorsal column proprioception. That's going to be an issue causing ataxia. Similarly, we also have the flocculonodular lobe receiving the inputs from the visual system and from the vestibular system. So that also is going to contribute to vertigo and ataxia. And then nystagmus because of the visual vestibular system. Pica is actually really dang common, so much that we're going to call it the Wallenberg. And I just remember the 2 L's for medullary for Wallenberg. And now we're down to the medulla, so this is cranial nerves 9, 10, 11, and 12. We have a little bit of cranial nerve 8 sneaking its way in there. So this can cause, because it's cranial nerve 8 involved a little bit, because it's the cerebellum, again, vertigo, ataxia, nystagmus. The gag reflex has to do with cranial nerves 9 and 10. Dysphagia has to do with cranial nerve 10, the vagus nerve, recurrent laryngeal nerve is going to come off of that and come up, and that can cause dysphagia. Sympathetic, because it's on the lateral side, Horner's, again, cerebellum. Anterior spinal artery. So for upstream, this is going to be the medial medulla. This isn't really common, but you might see it. In the medial, we have things like the motor, M for medial, and then the medial lemniscus is also, it's right in the name. So the proprioception might be thrown off. And cranial nerve 12 is divisible by 12, so this is in the middle, and this is in the medulla, so you're going to have issues with your tongue. Where remember, lick your wound. So if it's on the left side, I guess if it's an anterior spinal, might be both sides, but you're going to have trouble pushing your tongue out, and you might have tongue atrophy over time. Downstream, though, in the spinal cord, the anterior spinal artery, we just did this. This is really mostly just going to be maybe a little bit of corticospinal tract, so contralateral movement, but it's mostly going to be the spinothalamic tract, which is crude touch, temperature, and pain. Post-stroke pain syndrome. So if you have I think it could be a couple different things, but I think it's mostly a stroke of the PCA. PCA supplies the midbrain, and the PCA supplies the occipital lobe. Maybe a little bit of the ventral posterior aspect of the thalamus. Remember that for the thalamus, the ventral anterior goes to the motor, the ventral posterior goes to the sensory, and that also kind of lines up when we think about the precentral gyrus on the anterior side and the postcentral gyrus on the posterior side, having to do with motor and sensory, respectively. We see this trend really anywhere when we're in the head, out of the spinal cord, is that on the anterior side is motor and on the posterior side is sensory. So it kind of makes sense that this sensory issue is going to be associated with the ventral posterior. But basically, you get a stroke, and then 10% of the patients who have a PCA lesion, they're just going to have tons of random pain. And I guess that's the ventral posterior being kind of confused and just interpreting signals when there are none, or interpreting signals incorrectly, and it's just telling your brain to experience the sensation of pain. It's quite awful.